What is going on, ZPac? It's your boy, Z-Dog MD, a.k.a. Dr. Zubin Damania. Welcome to Incident Report. I have a special guest, Dr. Paul Teirstein, today on this podcast, and it is also an audio podcast, so if you're listening instead of watching, listen to the sexy tones of Z-Dog MD. Dr. Paul Teirstein is the Chief of Interventional Cardiology at Scripps. He is also the president of the National Board of Physicians and Surgeons, NBPAS.org. Last time we had Paul on the show, it was a fantastic discussion about something called maintenance of certification for physicians and how onerous it has become. Paul has been a champion and an advocate in improving this process for physicians, in rallying nationally, not only politically, but just at a grassroots level, and has a massive movement of doctors, myself included, behind him in improving our process. Today, he's here kind of urgently because we want to tell you about something that's going on in terms of a report that came out from the American Board of Medical Specialties about their own maintenance of certification process, and a rather urgent petition that we'd like you to take a look at in order to give us a voice. So many doctors and frontline healthcare providers, and by the way, if you're a nurse, if you're a pharmacist, if you're a respiratory therapist, it's still important to watch some of this, at least the first 20 minutes, to see what your physician colleagues are going through and see if you want to lend your voice to this petition to make our process of improvement better for doctors without burning us all out with measurements that don't actually measure real quality for our patients. So the idea here is that we as frontline clinicians who feel so much inertia and so much misery in terms of the kind of pressures upon us that cause us to have this moral injury of being able to just do our job for patients well is such a challenge, we can actually, in a grassroots way, have a voice and make real change. And that's what our guest, Paul Teirstein, has actually done. He's given us a platform and a movement and a voice to make meaningful change, not by overthrowing the system, but by actually changing it. And that's what we're going to talk about today. Everybody, please welcome Dr. Paul Teirstein. Thanks for coming on the show, Paul.
Well, great being here. Thanks for having me. It's been almost a year since I've been here.
I know, last February.
Yeah, we had a great time, and it was really powerful. A lot of people saw it last time.
You know,
a lot of people heard it.
I don't want to toot my own horn, but we're kind of awesome that way, Paul.
Yeah.
And actually, all joking aside, what is awesome is how a very busy clinician like you, who does a lot of work, you know, I mean, you're doing interventional cardiology at Scripps. You're seeing lots of patients. You're a busy guy. You also have outside interests that keep you busy. You got passionate about this because you were tired of doctors having to do work that did not feel meaningful, that did not prevent bad outcomes for patients or improve their care, but ended up generating a lot of revenue for an organization that's effectively a monopoly. And you've dedicated like the last 4 years to really raising awareness about this. So I want people who are watching or coming in and are going to catch this first 10 minutes of this to come away quickly understanding what maintenance of certification currently is for doctors in this country, why it matters to you even if you're not a doctor, and what you've been doing to try to make it more rational, more evidence-based, and more manageable for doctors who are burning out by the droves from this moral distress of having to please people that really aren't affecting patient care.
Well, you actually summarized it pretty well.
And we're out.
The maintenance of certification comes after you get initially certified, which 85% of doctors get initially certified. It has nothing to do with licensing. You know, we go to medical school, we take a few tests, the state gives us a medical license. But then if we want to be a specialist, including family practitioner, you have to take some more training, and then you take a test. That's your initial certification. Only recently have the organizations that certify us decided that we should have maintenance of certification, take continued tests to make sure we're maintaining our expertise. Sounds kind of good on the surface.
Right, because I mean, the medical field is expanding, the knowledge base is growing, how do we keep up? And MOC, or maintenance of certification, was a way to presumably keep us honest and engaged. And proving that we know what we're doing.
Sounds kind of good, but what's really goes on is first you have to pay a whole lot of money to a private organization. It's not a government organization. Then you have to take tests that are kind of meaningless. That the questions don't really relate to what you practice in. The questions are kind of obtuse, long stems, and then that takes a lot of time. You have to study for these tests. You have to take review courses, and you end up studying the things that you don't know because you don't need them, because you don't use them. It's very hard to do maintenance of certification via testing means that is specific to your own specialization. So this ended up being a lot of waste of time. And when I started doing it, 2014 is when I started trying to do my own maintenance of certification. I thought enough is enough. We really need to do something about this. It's not fair that this organization should ask me to spend so much time and energy doing something that's not helping me. It's not making me a better doctor. It's wasting my time.
Well, so here's the question, because people would argue, well, no, it is keeping doctors tested so that we understand their knowledge base. Otherwise, they could go out and, Dr. Death on the podcast, they're going to kill a bunch of people because they don't know what they're doing. Has maintenance of certification as a testing protocol and such actually been shown to do that?
So here's really, I think, where the new information comes in. You're right on point here. I've always argued that it hasn't. We've done a lot of work looking at the papers, the scientific research to justify maintenance of certification. We've had journal clubs. They're published on our website. And what do they show? They show pretty much nothing, that there's really no difference. It's very difficult to prove that one doctor is a good doctor versus another doctor. We all know this. We have doctors, who a lot of people think this doctor is a great doctor, and a lot of people think that same doctor is a lousy doctor. This is the way it's very hard to measure that kind of competence. And it turns out when you try to measure it scientifically, it's equally hard. So what happened is in response to all of this criticism, that this really onslaught of angry doctors, the American Board of Medical Specialties did a good thing. They said, let's put together an independent commission to look at maintenance of certification, which is abbreviated MOC. Mm-hmm. So there was this vision commission created last year. They've had a couple of meetings, 21 hours of testimony, and then they produced this huge report.
Let me just understand something. So they're measuring what they're measuring.
Right. Yeah.
Right.
Well, it's good because they need to know whether people are benefiting from this or not. Whether this is helping doctors or not.
Why are they even doing that? What's their motivation to do that?
What's the American Board's motivation?
ABMS, the overseeing board.
Because there has been a lot of us boycotting MOC. There has been about 20 state legislatures have bills pending. About 8 of them have passed bills prohibiting MOC from being used for insurance contracts and for hospital privileging. There's a tidal wave of particularly physicians who are against this. And so the American board decided that they better do something and better make some changes. A lot of the individual boards have made changes. Most of them not very good yet. Hopefully they'll get better. And this idea of the commission was to have an independent group of docs. They're appointed by the American board, but most of them are not associated with the American board. Look at the evidence. Hear from the doctors, hear from all the different organizations, hear from the public, hear from licensing organizations, and find out what they think certification should be and whether the current maintenance of certification is working well or not. And so that's what this huge 96-page report is all about.
Show me the report. So
I had to read this. You see, I have notes on it. It's like now the first 35 pages is the real stuff. It's the report. The rest is appendices. They're actually good appendices, though.
I'll tell you one thing ABMS is really good at is measuring stuff and writing big long reports. But actually, this gets to the point. So for people who are listening on audio only on the podcast right now, he's got like a multi-100-page document here full of notes. This idea that creating measurements that don't actually measure useful outcomes and affect patient care in a meaningful way, what it does, this is not a trivial thing. This is an existential crisis in medicine because as it is, everyone working the front lines in clinical medicine is under siege from everywhere. Whether it's insurance companies, whether it's financial stuff, whether it's malpractice. Electronic health records, which we've talked about. It's click, click, click. It's death by a million clicks. When you add every so many years that you have to pay a butt ton of money to effectively a monopoly organization to go through hoops that have nothing to do with your specific practice to prove that you're a quote-unquote good doctor to please the measurement industrial complex, when you have to add that can be the final click that will put people over the edge.
Right.
And so this is not a trivial thing. I want to make sure people understand this, that people think, oh, where doctors are whining about having to spend a little money and take a test. It's not about that.
It's actually worse because there are doctors losing their jobs over this.
Tell me about that.
So in fact, there's a class action lawsuit that was just filed, and 4 very brave doctors who were initially certified, and they are brave enough to say, I couldn't pass my MOC exams, and therefore I lost my job.
Yeah.
And so they're starting a class action. So actually, it's been filed already. So these people, and it's very detailed in the complaint that what happened to them. All the details. These people were not reappointed to their positions, lost their job. In some cases, couldn't work for a while. Had to look around and find new jobs. Had to move. It's a big deal. It really hurts people. And what I really like about the commission report, first, I read this thing. I read it thinking, oh, they're just going to gloss over it. Nothing's going to change. And I was really surprised. I was totally wrong about that. This was actually a good report. People should read it. I really want doctors to read this and everyone to read it. It has their findings are terrific. They actually document all the problems. I've got quotes. We'll get to this petition-like comment that we want folks to sign in a moment. But I pulled out quotes that are where they say, "Hey, quote the." The commission heard compelling testimony that loss of certification can lead to loss of employment. I mean, that's their findings. All right, so that's pretty harmful, right?
Yeah.
We're not supposed to do harm, right? I learned that somewhere.
Yeah, but these doctors are incompetent, Paul. They can't pass the test. Yeah,
well, the test is not a measure. The test is so flawed. I'll read you some more quotes, okay? There are gaps in the research evidence that conclusively demonstrates diplomate participation in continuing certification leads to better patient outcome. So they're saying the research has gaps in it. They're saying, well, yeah, there's research, but it's really it's not robust research, and it isn't.
And we knew that from our last conversation. Yeah.
They say diplomates cited the content of the examination was not relevant, was not a reflection of the application of knowledge in the clinical environment, and was not current with advances in medicine. This is their own report saying, hey, these tests are lousy.
Right.
Okay, and they're hurting people.
Right.
Okay, but then, this report does a great job saying that. That's the findings. Then they have recommendations. The recommendations, not so good. The recommendations are really weak. They say we should study more. We should collaborate more. We should have programs. We should have integration. I'm reading it. I don't get it.
It sounds like the wellness programs, right? Well, you should meditate and take lavender essential oils.
Pretty much.
Right.
These, and then at one point it says we should do something over the next 5 years. Okay, so here they document that they're harming people.
Right.
All right, and they document the reasons why. How could you not recommend to immediately have a moratorium on all the harmful aspects of MOC that you document? Yeah. They define the harmful aspects. They say it's hurting doctors. How could you not just say, okay, let's stop it until we fix it? All right, and there's a lot of ways to fix it. That we can talk about that. Some of it is unfixable, but there are things that can be done. But if we don't have a good approach, don't make doctors do something that's a waste of time.
Okay, so
it's hurting them.
And so this is where I think there's the urgency in this.
Correct.
And this is why you called me up this week and you're like, I'm going to be in Vegas. I would love.
No, I came here for you. Just so you know.
See that? I was making excuses for you being in Vegas, but you actually came to be here. And the reason is that there's an urgency to this because although the report is excellent, like you say, and it actually documents all the deficiencies of this maintenance of certification approach, the action items are very deficient. I mean, 5 years and talking more about it when we're in crisis now.
Correct.
Now, ABMS has arbitrarily said, well, by January 15th, right, we need
comments
from not just physicians but from the public about what they think about this report. Now, Tell me more about that.
So they're requesting for public comments, and there's a website you can go on to provide public comments. I think it's terrific.
We'll put the link there, yeah.
So what we did, I figured, okay, I got to better write my comments. So I started writing it, and I realized, well, why don't I write one that others can join if they agree with? So I wrote a fairly carefully written, and my friends and colleagues helped me, referenced comment, but my comment actually has references, little numbers, with referencing the vision report.
What
so
a nerd.
I can be nerdy when needed. And then we've put this online to where all you have to do is go to nbpas.org, that's nbpas.org, to our website. The very top of the homepage says if you want to read and if you agree, sign a petition-like public comment, click here. And you click, you write your name, and you say if you agree. We'd like to know if you're a doctor. We ask you to check that box. If you give us your email, that'd be nice. But the whole thing's going to take you 30 seconds, although I would like you to read the report.
Yeah.
At least if you read what you're signing, you'll read the quotes from the report, because I have them all in there.
Right.
So it's a way to get feedback, because I think that this can really be helpful. This Vision Commission report can be helpful if used correctly.
Right.
And they've really got to do something about it. There's documented there's a problem, an urgent problem. Let's fix it.
And this is what lit a fire under me, because, the last time we talked, we were talking a lot about, well, what are alternatives to ABIM and ABMS and the board, the MOC process. And, you said, one of the ways we can sort of fight this, this bureaucratic intrusion that doesn't help patients is by creating an alternative pathway. Right. And we had different solutions, which we can talk about. But right this minute, what matters to hundreds of thousands of doctors is that their voice and the voices of their colleagues, so nurses and pharmacists and everybody who works with them, are heard regarding this particular report, which is pretty accurate in explaining what the deficiencies are. So the way to do that is go first, read the report if you can, look at the summary, we'll give you the links, and then check out the petition. If you agree with the points in the petition, what are you basically, what in your petition are you saying that people are getting behind?
Right. So by the way, you can we give you the link also to, if you want to write your own comment.
Write your own comment, right, exactly.
And if you want to cut and paste some of our comments into your comment, that's fine. So we really recommend, our comment has 4 aspects. One, an immediate end to requiring secure pass-fail exams, all right? Because that is really, and the report makes it really clear that is not a good way to do continuing certification.
So you mean like the every 10-year exam that you sit? Or
now it's for ABIM, that's internal medicine, which is 1/4 of all doctors, and you're a part of that.
Yes, sir.
That's if you're a GI, if you're a cardiologist, family practice, internal medicine. Yeah, that's ABIM. They have it. They give you an alternative called a knowledge check-in. The knowledge check-in is an every 2-year exam, but it is and it's highly criticized in this report. And if you talk to do you know anybody who's taken it?
The MOC,
the knowledge check-in?
I certainly haven't taken it yet.
So if you talk to people taking it, besides the technical problems they have with the whirly-bird, because you take it in your office, it sounds good, right? Except that, get this, there's a video camera on you. Okay, and you have to have the video camera on you, and then they tell you to move it around to make sure no one's in your office with you. It's bizarre, and then you can use UpToDate as the only resource. You can't Google things to answer questions the way I would do it in practice, right?
Are they getting paid by UpToDate?
Well, they're getting a lot of UpToDate. Certainly gets, they must get some marketing from this, if nothing else. I don't know what.
Right.
Who knows?
I love UpToDate. Don't get me wrong.
Yeah, but it turns out when you're taking the test, it's not so easy to use UpToDate on it. It's just technically hard to find. It's the navigation that's hard. The test is 3.5 hours. And apparently they're giving you more time because there's so many technical difficulties. But would you rather do every test every 10 years or a 3.5 hour test every 2 years? I mean, it's the same thing.
Every 2 years.
Yes.
Okay, let me just get freaking angry for a second, because as it is, we're nickeled and dimed and tortured. If you want to let us take care of patients, do things that actually help us do that. Help us actually understand the data of our fellow physicians and how they're practicing, so we can compare
ourselves. You just said it well. So you're leading right into what's good about this report. I make a distinction between a formative assessment and a summative assessment. Now, I know you know what that means, right? Right. So this is funny. Educators have like lingo, just like doctors for everything.
Teach me.
So I had to go to the appendix, of course, which is where you find the glossary. And if you look up formative, I guess it means it comes from the stem of inform, I guess. The idea is learning. The assessments should be a learning experience, not a punitive experience. So if they can actually come up with a learning experience with things that I want to learn about because I need to learn, or things that I need to learn about from my practice, that sounds good, right? Mm-hmm. And what they say is it shouldn't be a summative assessment. What a summative assessment is, you have to read it again. That's basically a pass-fail exam. It's either, okay, you're in or you're out.
Right.
And that's what we don't need at that level of education once we've already been certified and we're out in practice. Right. We don't need a summative. And the report says that very clear. The ABM knowledge check-ins are summative.
Yeah.
And they're spelled out in here. They are this Vision Commission's report is very, very critical of them. So I say in the comment that I'm hoping, already have over 10,000 people have already joined it, but I want more.
Yeah.
Okay, because I think more agree with it. We just have to get it out.
Yeah.
Which is why you have to pass it around to your colleagues and your medical staffs. You got to. There's a link there. Just put it in your email and send it to everybody.
I'm going to put it all over the place.
So one is an end to these high stakes, secure pass-fail exams. Second, this is a really complicated issue, an immediate end to requiring the quality initiative, practice improvement stuff. Have you done any of that?
Ooh. So yes, I did one of those modules. It was like poking something in my freaking eye. It was a made-up exercise that you have to go and do a quality improvement. Listen, actually go and improve quality. Work with teams. Do your thing. Why should you have to do some busy work that actually, it's a quality measure that doesn't measure quality, which we've been yelling about on this show from the beginning. This is the origin and the sustenance of the measurement industrial complex. These people are paid to torture us for no evidence that it actually does anything for patient care. And you know what? It's an assault. And this is where I get really pissed off, because this is an assault on me as a sovereign practitioner. Yes, I want to connect to best practices. Yes, I want to actually even compare myself to how other clinicians are doing. Yes, I want to reduce variation of care and find outliers and make sure that we're practicing evidence-based medicine. This doesn't do that. This is a torture. It's the kind of work your school teacher used to give you, and you would go home oppositional defiant and want to leave school.
Well,
maybe it was just me.
No, you have said it more passionately than I could have ever done. I'm really glad you've had this experience.
I might have
injured myself. No, what you see, the reason you're going to like this report is this report says things like this. It is acknowledged. They don't say it quite the way you say it. I mean, you say it better, but
I would have dropped F-bombs, but I'm being nice to Paul.
It is acknowledged that measuring practice improvement can be challenging. Okay, so that's good. That's a start. Then it says the commission appreciated. You're going to feel heard here. The commission appreciated the practical and significant difficulty placed on diplomates for meeting practice improvement requirements. And then get this: diplomates did not find value in checkbox activities or activities not relevant to practice. Diplomates complained that requiring multiple PDSA. Do you know what that is? I'm glad. You ask any of my fellows, they all know what that is. That's Plan, Do, Study, Act. It's a cycle. It's an educator's way of putting into words what is sort of common sense. It's what you were asked to do. It's actually, the title of it is a PDSA. But requiring multiple PDSA cycles in quality improvement activities, or requiring improvement in an activity in order for the activity to count in the certification program, was onerous and artificial. So they said it right here, what you just said. They said it a little more, professionally. Okay, but they say it. So I'm saying, great. Just do something about it. Okay?
Do something.
Yeah.
So the point of signing this petition is to make your voice heard so they actually are more likely to do something.
Correct.
Do you think they will if they hear a lot of voice?
I somehow got this epiphany 2 weeks ago when I wrote this, that, maybe this is the way to do it. I mean, it's their own commission.
Yeah.
And they're going to get there anywhere, I can tell. They're going to get there.
Yeah. But just
stop it now. Let's get some action. Right? Yeah. That's what I'm really asking for.
Yeah, and I'm with you 100%.
So there's two more things. One is a reduction in fees. So there's a lot of economic discussion here because these boards are not for profit, but they make a ton of money. Your board and my board, the American Board of Internal Medicine, it's $65 million a year. And this is like a toll booth. right? I mean, you charge a couple $100 per doctor, and you got 200,000 doctors per year. That's a lot of money. Now, it is a not-for-profit, but I've learned, most doctors don't know this, but not-for-profit doesn't mean not for money.
It
All
means
right?
for money, but we put it in something squirrely. Yeah.
And there's a lot of high-paid administrators, and and that comes up in the report. There are quotes which I can read you, but I don't think I have to bother. There's from the report saying doctors don't really trust where the money is going. It's their hard-earned money. They want some transparency. So in this petition-like comment, we've written, we'd like a reduction in fees charged for MOC, preferably to under $100 a year, irrespective of the number of certifications maintained. So, some people think that's too high. You're never going to get everyone to agree about it. It's going to cost something, but it doesn't have to cost much. And you don't really need to do much. You don't have to pay this board, that board. I mean, if I'm an interventional cardiologist, I should do my certification in what I'm practicing in, and then I don't mind paying something, but I shouldn't have to dole out. Like right now, it's about $450 a year because I got 3 certifications.
Right.
So we're asking for a reduction of fees. Also, we're asking, I'm taking the opportunity to say, this was not in the division report, but I think they need an independent, this is sort of a monopoly. And the Department of Justice gave this opinion letter recently.
I heard about this. Tell me about this. Yeah.
Well, it's an opinion letter that essentially states that the American Board of Medical Specialties has monopolistic aspects, and they are. I mean, there's really no one to compete with them. Your hospital is not going to accept the National Board of, I shouldn't say that. We have 120 hospitals have accepted the National Board, NBPAS.
Of which I'm a diplomate as well. Yes.
But you're going back to Stanford, I understand, right?
I am.
I bet Stanford's not on the list yet. That's your job, okay? Get them. It's not so easy. You have to go to the MEC. You have to get them to approve it. And insurance companies are very difficult to deal with if you're not certified by the American Board. So it is a bit of a monopoly.
Yeah.
And what the Department of Justice said in their letter is monopolies are bad. It's harming doctors. It's harming patients because fees go up. Competition turns out to be key to everything.
Yeah,
as
and
we all know.
transparency.
And transparency. So we're asking for an independent. I'm asking you for an independent, or we're asking for an independent organization to have oversight over the finances. Yeah. All right. I mean, how much is this doctor going to get paid to run it? Well, what's reasonable? I mean, they should get paid a lot, but there should be some control over it. Right. Do you know? And this is not part of MOC, but do you know what my fellows have just told me? They just got finished taking their interventional cardiology boards. What do you think they had to pay? These are guys making $70,000 a year.
I'm going to suspect it's a couple grand.
$2,950.
That's absurd.
Almost $3,000.
These are
forgetting
fellows.
Review courses. These are my fellows. They don't make any money yet. I mean, they're and that's the initial fee. I mean, and that's just. I mean, I call that in if you read the petition, that's basic unprofessional. I mean, it's professionalism is ethics. That's unethical.
Yeah.
To charge that much. So there has to be somebody saying, okay, let's cut down all the costs. I mean, I know, an organization that's spending $60 million a year. That's just ABIM. I mean, all the other boards all together, I think it's something like $200 million. Let's cut the costs down. Let's get a whole handle on this. And, be frugal, just like we're trying to cut costs in everything in medicine, right? How much time do we spend trying to bring down? I just finished negotiating stent prices.
That
we
sounds
spend a lot of.
unpleasant.
It's not fun. Every year we try to cut the costs. So let's cut the costs of certification.
Well, think about all that money, that $200 million across the boards. Think about it being applied to actual measurement processes and artificial intelligence that actually improve real outcomes.
Right, and I think they can do a better job. These boards, if they have to be willing to say, "Gee, we were wrong. We're going to start from scratch again."
But if you don't do the MOC and these sort of busy work activities, what do you do?
So here's what we're recommending is until you've got it figured out, go back to CME and professionalism, which is having a good license and good standing, not being kicked off your medical staff, not being in jail for fraud. But
it's necessary but not sufficient. Like not being in jail for fraud. It's one of those things that it's required but not entirely sufficient to be an awesome doc.
Right. Yeah. But the National Board, NBPAS, we rely on accredited CME, and we believe in that. We love that. So that's what we're saying. Go back to that. Until you've got it straightened out as measured by either robust evidence, which is almost impossible to have, or at least a general consensus. So let me give you an example. And what I'm going to say right now is controversial because you're never going to get everyone to agree on everything. And I get hundreds of, you wouldn't believe the emails I get every day. Probably 100 emails on this topic, probably more. And there are a lot of doctors that just think it should be done away with. MOC, you get your certification like the grandfathers have. By the way, the grandfathers don't have to do any of this.
Which is, by the way,
ridiculous.
So, because what are the grandfathers? They're mostly men. They're mostly white men. So in a way, this is like a racist, sexist act. But where's the outcry? Where's the call-out culture calling this out? Nowhere.
It's really a big problem that these folks have. Is that why if it's so important, MOC, why don't the grandfathers have to do it?
Right.
You know.
Because we're the grandfathers. Damn it, Teirstein. You shut your mouth, Teirstein.
Spoken just like a grandfather. I forgot entirely where we were. Oh, so we were where, what should we do? So there may be some better ways of doing this. So for example, you're going to see a paper, I think it's in New England Journal next week, looking at the MOCA Minute. So the MOCA Minute is anesthesiology. They had the worst maintenance of certification.
Anesthesia.
They used to do. Theirs was the worst, and they had to simulate. They had to get on airplanes, go to a different city to do a simulation. The doctors were so furious. Now they get this thing, and it's not perfect, believe me, but it's kind of cool in a way. You get this. You get emailed questions, and the number of questions is, I think it's 30 every quarter, so 120 a year. The part I don't like is you get a minute to answer the question.
The MOCA Minute.
Yeah. And then it tells you if you got it, and you also have to tell it how comfortable you are with your answer. Do you think you got it, or do you? So the idea is to identify knowledge gaps.
I see.
Okay. It gives, if you got it wrong. I guess I haven't done it. I'm not an anesthesiologist, but you get feedback immediately of what the right answer was, why your answer was wrong, other resources.
So you get taught.
That's the idea.
Yeah.
So now, where this can go wrong, it can go wrong is if the test questions that they give you don't relate to your practice. So I don't know yet if they've got that figured out. But the big thing is, how is it graded? So you'll love this. I've had like 5 anesthesiologists so far what they think of it. 3 thought it was good. 1 thought it was okay, and 1 thought it was just a moneymaker thing. So you're not going to get everyone to agree. But then I said, so how do they grade it? We don't know, but we always pass. So I think that's how it should be, though. It's supposed to be learning, not punitive.
Right, not punishment.
So they're gonna have to come up with some way to decide that a doctor is not worthy. I get that.
Yeah.
I don't know how that's going to happen, but as long as they're not decertifying doctors.
Right.
Because I suppose if they give you the same question 5 times, you can't get it right. Okay, maybe that's going to be
There's
the kind of metric.
There's a cognitive deficit. Yeah.
The other one that, and by the way, in the New England, in this paper that's going to come out next week, I believe there's a survey. And the survey was done by the American Board of Anesthesiology, so it's not an independent survey, but they surveyed a lot of their doctors and said, what do you think of this new thing? And 82% of them said they thought it was helpful. So I'd like to see an independent survey, but I'm going to assume it's on a survey, and because I don't think you're going to get robust evidence for to prove that this doctor is doing a good job versus this doctor's not. I think it's very hard to actually measure that objectively.
That's been the big challenge.
Yeah. But if you can get 80% of your doctors to say this is okay, that's a lot different than, remember,
what was 12%, the survey result?
12%.
12% of doctors in their own survey said that this was useful.
Well, was useful, yes.
Yeah.
And now with the new MOCA Minute, when they surveyed their doctors, 82%, I think it was, said that it was useful. So they improved it. That's certainly going in the right direction, right?
Yeah.
The other one that looks promising, and I haven't seen this one yet, but I kind of like the idea. It's OBGYN. So what they do is they give you, I believe it's 30 articles. So they come up with what they think are key articles in the field. And apparently what I like about this is you can choose articles you want to read. Now, I spend a lot of time reading articles. I have to. That's the only way I can stay up, right? I don't know. Do you read any journals?
I'm supposed to.
Right.
Sometimes for shows, I'll read stuff like the paper. Kidding.
Okay.
Yeah, I do.
Well, I get. In fact, it's almost too much. I get 6 different journals every week.
You're
I'm
such
getting
a gunner, Paul.
No, I have to do this, right? Otherwise, and I got to read them, and I do, and I think it's important. For me, if I was going to get 30 journal articles or pick out 30 of, hopefully they give me 50 or 60 or I don't know 100, I could pick out 30 that I would want to read anyway.
Right.
And then you read them, and then you have to answer 4 questions at the end.
That's great.
What's wrong with that? And then also it gives you, like, if you got the questions wrong, it gives you more info, and it's not one of these things that's pass-fail.
Right.
Again, I don't know how it's graded, but when I ask the OB guys, they say, I don't know, we just pass them. It's not really, you're not really going to get them wrong. I mean, you're just answering questions. Just look at the paper.
You go through it, you do it, you learn something.
So that's being helpful. Now,
yeah.
Both organizations, the American Board of Anesthesiology and the OB/GYN Board, which is OG, there's so much alphabet soup in this business.
Yeah.
They also have practice improvement in there. So they don't have it figured out yet.
Fixed it yet, yeah.
Yeah, but it's a start. I'm saying there are ways of solving this that are formative, to use their terms,
as
instead of
opposed to summative. Yes.
Exactly.
See, I've been learned here. You can test me now, board. I will pass. I got maintenance of pimpiness.
So this is a very easy thing for people to do. It'll take you under 60 seconds. So we want you to go to the NBPAS.org, NBPAS.org. Very at the top, it says click here to sign this, and it'll take you to an explanation with references. The whole thing will take 60 seconds, and you click again if you want to go to the petition website. If you want to do your own comments, you can click there. We're just trying to get responses and get people awakened to this.
NBPAS.org is where you can go, and you'll find a link for that. And I'll put in direct links in the show notes and also in the web post that we have.
And as an alternative, we're doing great. We have over 7,000 diplomates now.
So this is the National Board of Physicians and Surgeons, of which you are the president, and you helped found, if not did found.
Yeah, in my kitchen.
In your kitchen. It's like, Wozniak made the Apple computer in his garage. You made an alternate credentialing association in your kitchen.
It's a big kitchen.
And so I went through this process after our show last time.
Yeah.
And it was really, really interesting, because I thought, well, let's see how easy or hard this is going to be, and whether this is Mickey Mouse or whether it's legit. And this is what happened. They asked me for a shice ton of CME.
Right.
And they wanted to make sure that all my licenses were active, and I hadn't had any, Michael Jackson's doctor giving him propofol unlicensed anesthesia. And I submitted it all, and I was like, hands are done. Let me get my certificate. I got an email back.
Oh, good. This is obvious. Good
and it
feedback.
said, Dr. Damania, as you might imagine, we are very careful about making sure that you are credentialed and appropriately CME'd up to be a diplomate of the American National Board of Physicians and Surgeons. There was a concern we had with your CME. The dates on one of these overlapped 2 years, and we need very specific granular data to show that you did this within the prescribed time frame, or else you may not have done enough CME. And I tell you, I've never had, because I use UpToDate for a lot of CME, and it gives these ranges. They were very specific. So I had to go into UpToDate, figure out how to get it granular. It's a difficult process to do. Got it, sent it back, waited, got the result.
Wow, what a great feedback. So that's great. 2 things to say about that. One is, what a great office staff we have.
They're great.
These guys, this is Lauren and Carrie. They're doing a great job. Brittany, it's run by Katie, and just phenomenal people. So they're really doing their job, which is great. However, the only issue that doctors have is getting that CME certificate to us.
Yeah.
Some of them don't know how to do PDFs, and
Right.
so we give them some advice. You can take a picture of your CME and send it. And all we want is 50 hours over 2 years. So you're getting that already, but at least you have to attest to it to your state, but maybe you don't have to send it in. We have to see the certificates.
Yeah.
But I've talked to the AACME president.
Yeah.
That's the agency that accredits CME. And I say, this is the modern era. Why do we have to have these certificates? Why can't you have the certificates? You hold the certificates. And when I need to find out if ZDog has done his 50 hours, all I have to do is query you.
Yeah.
And I'll pay you $10 for that or
Right.
something. You
It's
can
worth
make
it.
money.
Yeah.
I know you're not for profit, but you can. This is an opportunity for you guys because it'll make our headaches less, and your headaches would be gone.
Right.
And how long did it take you to do to apply for the NBPAS? I mean, how long was
like
that?
literally less than an hour. I mean, I pulled the certificates from Evernote where I have them, and I went through the application, and I made sure.
So
I
if
got
you
everything.
have the certificates with you,
Yeah.
like if your secretary
all
has them,
organized, yeah.
if you have them with you, it shouldn't take you more than 15 minutes
Right.
to fill out the form.
Right.
And it costs I think we're at $169 for 2 years.
It was
and
a
then,
bargain.
And then the
Yeah.
renewal is $149 for 2 years. So
right. And that just pays the overhead.
Yeah,
Yeah.
we're actually breaking even if we didn't do politics.
Yeah.
Okay, if I didn't have to go to Washington and testify
lobby.
to the Department of Justice, then we would be making too much money, so we would cut the fees back.
Right.
Because we don't really need to make money. The other thing I should say, though, is none of us are getting paid. So I don't get paid, and we don't have the staff gets paid, but we don't. The physician board members. And I don't know if you looked at the board is pretty amazing. I mean, it's a very academic board.
I saw it. Yeah.
We're not getting paid. So if we were to pay people, then we'd have to probably keep them. We wouldn't have to charge more. But if we got rid of the politics, we could probably pay the directors a little bit or something, and then the price could go down a little bit is what I'm getting at.
Yeah. And that's
Yeah.
this is how it should be. It's
Right.
by physicians for physicians, peers working together
Try to
to
be
try
helpful.
to make sure.
We're also nice. If you call or if you send us an email, we respond. We don't act like we're arrogant. I don't know if you've ever dealt with the American boards, but they can behave very arrogantly, as though you're just a puny doctor, and if we'll maybe give you this certification, but we're not going to do it because you didn't do this, that. We're very polite. I write a lot of polite no notes to doctors saying, hey, I wish I could certify you, but you know what? We're being held to really rigorous standards.
Yeah.
And this certification, this CME you got, it's not accredited.
Yeah.
And you can't tell me that making rounds with your fellows is CME. That's just not CME.
Making music videos, Paul Teirstein, is a CME accredited activity as far as I'm concerned. It's preparation. Actually, I should get 2 hours for every hour.
You'd have to get it accredited. So there's some rules and regulations
Yes.
about that. You could actually try to get it accredited.
So we are accredited for CME through our partner Physician Weekly, and in fact,
So you know all about it, yeah.
Yeah, and so the idea is again, get your CME where you are most connected in terms of the capacity to learn.
That's
Right?
Who would? Why would you do anything else?
Right.
I mean, you want to get CME. Doctors like to learn. Doctors are not lazy. That's one thing I can
That's
tell
a
you.
frickin'-
It's really hard to be a doctor.
pretty diligent, yeah.
And so, and doctors like to learn. We're here to help patients. We want to do better. So if we're going to do it, if we have to do MOC, and I don't think some of the emails I get say you're crazy. We shouldn't have anything to do with CME. With MOC, that should just stop once you get the initial certification. I don't think we're going to get that. I think it's going to be continue. We're going to have to do some kind of continuing certification. But why not make it worthwhile?
Yeah.
Why not make it something you can learn from?
Yeah.
And be helpful.
You know what would be cool is if we can start doing shows that actually help contribute to MOC, not in the click box way, but...
So I've been thinking about this, and maybe you and I should knock our heads together. One thing I've done, which is very hard to get traction on, is with my technical buddy Sean. I started curbside.org.
Curbside.org.
Yes, and the idea is physician asks a question related to it. Usually it's it's something you can't look up in a book. I got a patient who's got a bleeding problem. I've got to give him a blood thinner. What's the best way to handle this? Something, it's basically ask a colleague, get a curbside consult. Right. All right. So it's, again, very easy, very user friendly. You write the question, and then it asks the community to answer it.
Yeah.
And often discussions occur. And then the answers get voted up or down, so that you could see what a good answer is.
It's like Quora.
And we're giving CME for that. Now we're trying to keep. We don't want to abuse it. So it's like I think it's 15 minutes of CME per question you engage in,
right?
And no more than 10 hours a year is I think we're putting some limitations on it because we're trying to make sure it doesn't get abused. But again, we're trying to do just what you said. Why don't we think of fun ways where we can help doctors learn that aren't outside, that are not the usual go to a course. Not that the courses are bad. I give a course. I love it.
Yeah.
But there's other ways of doing it that might be interesting and helpful. And this idea of asking a colleague curbside.org. I mean, I find that really helpful. You can ask these are real questions.
That's how we actually do it in the real world, man. When I was in my multi-specialty group back at Stanford, the greatest thing was I walk over to the equivalent of Paul, who might have been Asian, and Asian Paul. I say, Asian Paul, I'm curious about the efficacy of this left anterior descending stent in this patient with diabetes, or should they go for bypass?
Exactly.
And then Asian Paul would explain it to me.
That is so funny. I don't even know what to do with that, but I'll just stick to the.
We bristle when people make us do busy work that doesn't help us. We want to feel meaning, right? Like, I think
the point.
Wendy Dean and Dr. Talbot, I'm forgetting Dr. Talbot's first name, they wrote an article in Stat a little while ago about how it's not burnout. It's very similar to what military veterans suffer. It is a kind of a moral injury. So in other words, when you're asked to serve multiple masters that don't actually improve patient care, or that are at contradiction to your own moral compass, then it creates a kind of distress. And military people who have to go in war and see children murdered and things like that, they suffer a deep injury, and it's not a physical injury; it's a moral injury.
Right.
Physicians, frontline healthcare workers, nurses, every single day are suffering moral injury at the hands of faceless bureaucrats and system problems that force us to behave in a way that we know is not good for our loved ones, our patients, our family, our sanity.
Yeah, and it's hard also to get that across, because it looks like on paper, it looks like maybe what they're doing is okay, but it's not okay.
That's the thing.
Yeah.
It looks good on paper.
Yeah.
And this is how the whole measurement thing is happening. People like Don Berwick, who are part of Institute for Healthcare Improvement and this big thing about measuring, better, improving safety. He himself is now saying, listen, we need to cut measurements by 75% because these things don't actually measure real quality.
Well, I so agree with that. That it becomes a waste of time. Everyone thinks you have to measure everything, but actually the measurements are not they're not valid measurements.
Right.
So it's a waste of time. I mean, if you're going to measure something, measure it, have a valid study.
Now, one thing I will say is I'm very sympathetic to this idea that we get a lot of stuff wrong, and we have a long way to go in improving patient safety. And anytime you work in the hospital, you just see the Byzantine ways that things can go wrong. And
it's amazing.
It's amazing.
Because we're dealing with people, and it's just really hard. People, they make mistakes, they get things wrong. And you try to have systems. I mean, usually it's a form.
Yeah.
Every problem we have in the hospital, we have to have another form,
right.
And it gets added. And I'm not so sure that really solves the problem either. It's very hard to, when you're working with human beings, for everything to go smoothly all the time, which is why you have to be alert.
Do you think the answer should be more mechanization and more AI, or is the answer better humans and better processes, or is it some mix?
Well, it's going to be a mix. I don't know if we can get better humans for a while. I mean, there are a lot of things I complain about humans. But I think we can do a lot of improvements.
Yeah. We are definitely the rate-limiting step in many reactions.
Yeah, but I have not been thoughtful enough about how to globally solve the problems. AI would be great if you can have a computer do it, but the computers tend to create more busy work. Also, right, on the EHR, I mean, on the electronic health record, you check this box and it tells you can't give this drug because of something that's got wrong, and has to do with the programming. But so now you have to fix the programming, and
one thing that was brought to my attention recently by a pediatrician who runs a practice back east. He messaged me and said, what are your thoughts on peer review, on really extensive peer review? So what he does in his multi-specialty group is sits down with doctors, goes through charts, and they're still on paper. So they can just sit there and go, okay, well, let's go through this. And, okay, what did you do here? What did you do there? And let's really have an honest 360-degree feedback on it. Have you guys done any of that stuff?
Yeah, so our peer review is done in several formats. One is M&M conferencing,
That's
which
an important one.
we really like to do. We do a lot of that, although it's done in a group and it's all confidential. It's not. I think what you're describing is more of a one-on-one thing, right? Where you can probably get a little bit more granular and a little bit more nasty about it.
Or constructive if you want to use it, if you're nasty.
The other thing that goes on in our institution is there's a committee that meets And that committee, anytime there's a bad event, looks at it, and someone reviews it, and those are variable. I mean, sometimes it's a good review, and sometimes it's the patient died. The patient was heart failure, 95 years old, and we tried to save him, and it didn't work. So sorry. I mean, sometimes you feel like you're getting accused of something, and there's really nothing you could have done. You explain that to the committee, and it kind of usually goes away. But I think both combination. We think those two things work pretty well together.
Yeah.
But I think having supportive physicians in your environment who keep an eye on you, having fellows. I think my fellows are really great peer review. They look at me sometimes and they say, "I don't think we should do this," and I think that's very helpful to me to get someone looking at me all the time and giving me feedback. Our staff.
I'm 100% with you on this.
The nurses give us feedback all the time.
Nurses are tremendous saviors of us. Fellows are saviors. Residents are, and we like to complain about them and all of that. But the truth is, like, when I'm practicing with an academic team, I'm learning the whole time, and I'm being kept on my toes the whole time. And this is why people ask, well, is care. When I go to a teaching hospital, I don't want to have residents. I'm going to try to tell them not to have the residents see me. It's like, you're making a huge mistake. The teaching hospitals are where I think the best care is given in the country. And I'm biased, but I really think it's true.
I couldn't agree more. I think that it's a terrific environment. Not everyone can be in it. So, I mean, and there's a lot of non-teaching hospital environments that are phenomenal.
That are great, yeah.
But I think, I was offered. Someone wanted me to start a heart hospital about 20 years ago in San Diego.
Very lucrative.
And I could have made a lot of money. Yeah. And I decided, I looked at it and I said, the only reason to do this would be to make money. And that's not what I kind of went into this for. And the main problem was to build a teaching program from the ground up would have been probably impossible or taken my lifetime. And I couldn't imagine working without residents and fellows. That wasn't the way I like to do it. I mean, so I value teaching programs.
Yeah, I do too, and it's not for everybody, and I think some people do very well. And there were days when, when they started pulling our house staff away, that's when I started burning out more, because I realized that camaraderie, that sense of connection. Plus, everybody's personality is different, right? And we kind of gravitate into specialties and niches within specialties that are good for our personalities. Like, you are a high energy, multitasking machine of energy. Like, talking to you offline is exhausting because you're so high energy. But it doesn't exhaust me because I'm an extrovert. But I can imagine people would just be like, my gosh, this guy does so much. And whereas, for me, being an extrovert, liking to have the interaction in real time, having a team that rotated, so it was always somebody new to hear my same stupid jokes, was crucial, right?
I can't believe you said that. I mean, that's what I love about the fellows. Like, I can tell my jokes again.
It's the same thing.
It's like
I'm like, the thing is, and they look at you like you're a genius because they're hearing it for the first time.
Or what I really like to do is when we're doing technical things, putting stents and heart valves in, and I love some of the stent things I do, and I show them a maneuver they're struggling with the wire, they're having some trouble with it, and they say that was really. So I show them how to do it. He said, that was great. I said, yeah, Dr. Hartzler, my teacher, taught me that in 1986 or 85. So that's a very gratifying. Yeah, really is.
Right.
Yeah.
And you're teaching a technical skill as well as the intellectual stuff behind the the management of those patients.
And you can watch that. You get to watch them progress, and then they get really good, which is phenomenal.
Did they ever get better than you?
Oh yeah.
Yeah.
Oh yeah. I got two of them are working with me now. That Matt Price and Curtis Dennis. They're way better than me. I taught them how to do it, and they're just better.
Now you're like, I must kill you.
No, I'm fine with it.
Oh, sorry, have them killed. Paul, come on. You're so advanced now. You don't kill people with your own hands. You have to go and hire someone, and it's a whole thing. I know, because I'm with you.
What are you talking about?
I'm with you. Oh, wait, is this thing on? Now, here's just a personal note as we wrap up. You just got a jet airplane license.
But not a jet.
I
didn't think that was really
cost effective.
Yeah, it was kind of.
I'm like, what are you doing with my fees for NBPAS?
I just wanted the challenge of learning how to fly. We're talking about learning and teaching. So if you are out of school, you forget how hard it is to be in school. Learning that's a really tough position, and it's easy to forget what it was like having to take these really hard tests, being evaluated all the time, and actually also being on the learning curve where you don't know anything. So for me, aviation, which I just started about 7 years ago, has been a great way to kind of have empathy for my fellows, because you get into that position where you are the low person. You don't know much, and it's really important that you learn this stuff. So to me, that was a way to kind of ratchet it up a notch, was to learn how to fly a jet, which is hard.
Yeah,
much
wow.
harder than I thought.
A jet. So relative to like a Cessna or something, it's a different game.
Much harder, because I thought it would be harder to handle the plane. Very easy. That it's taking off and landing is the easiest part. The hard part is there are literally, for the little jet that I learned, it's called a Citation Mustang. There are 200 memory items, like what temperature does fuel freeze at? Because you're up there, it's important. There's all the weight limitations of the aircraft. Then there's the checklist. There are a couple hundred checklists, and 20 of them you have to memorize, because you can't like look it up, because you depressurization at 40,000 feet.
You got to just go.
You have to know exactly what to do, and so it's the mental stuff that makes it hard. Not flying the plane. It's really all the knowledge that you have to learn.
Has that informed your medical practice?
Well, it actually relates to maintenance and certification in a way, because people always say, well, our pilots have to go through recurrent training, so why don't our doctors? And I think that's a reasonable initial assessment until you find out what the pilots do.
Right.
And then you realize that it would be great to do this in medicine, but it's never going to really happen because it would be just too expensive. But it would be great. So if you're a general aircraft aviation pilot, you fly Cessnas, every 2 years you have to have a flight review. So you go with an instructor that you pick, and you spend a few hours with the instructor talking and then flying. So if I was able to select from a list of potential doctors in my community, one to spend an afternoon with me as my maintenance and certification. Now that would be great.
Yeah.
I would learn. They'd say, hey, why don't you try doing this? Why don't you try it that way? And then the guy certifying me or recertifying me would learn a lot from me too. It would be a cool experience, right?
Wow.
So that would be a nice way to do it. But you'd have to certify the doctors who were going to then
to do the training,
yeah.
to do the certification, and then it would probably be academic guys or gals, and but
you have to pay them a little something. But
that would be money well spent.
Yeah.
That would be money I'd be willing to spend.
Correct.
What an interesting thing. Maybe we ought to be pushing for that.
Well, I've suggested it. It's just the issue is it's
onerous.
It's hard to pull it together, and then who are the doctors that are making sure it's done right and.
Who certifies the certifiers?
Yeah.
Yeah.
Well, that's done in aviation very well. I mean, that's really done well. I mean,
right.
Aviation really has it down.
Yeah.
That the whole instructor, to be a certified flight instructor, a certain amount of training, and then you have to have another certified flight instructor review you. And since it's, life and death stuff like medicine, they take it seriously.
It's funny because I was going to say, my instinct was, but Paul, but that's life and death stuff. Of course they have to take it seriously. And then I was like, wait a minute.
That's what we do.
That's what we
the
do.
Point. Yes.
And in fact,
right.
we probably crash a few jumbo jet worth of medical errors, every day.
So why not do that? I think that would be the best.
Yeah.
Way to do it. And I don't think you get many people objecting to that.
And I'm going to bet most people would enjoy the process because they'd come away better for it.
Yeah.
And I bet the certifiers would
the other
too.
part that we could talk about relating to aviation is simulation. And I have not, honestly, I don't think this works so well in medicine because there's just so many different scenarios. And I've never seen anyone get it right. But in aviation, what happens is the recurrent training for jet pilots, most of it is usually done in a simulator. So that the idea is to have failures. Is you do the same thing with an examiner. You do it actually every year or sometimes every 6 months, and you spend a couple of days and things that you don't want to have, you can't really simulate in the jet, like loss of pressure. You can't really do that because you ruin the jet.
Die, yeah.
And, right. But you can do it in a simulator, and you do that. That's part of the, so that if it should ever happen, it's instinctive instead of having it to be, oh my God, I've never seen this before. Can I get on curbside.org and ask somebody? You can't do that.
Right.
So,
We do an up-to-date search.
I've thought about how to do that in medicine, and I just don't. The problem is there's very definable failures in the aircraft, discrete, which I'm not in medicine. There's so many different scenarios that it's a challenge to do. But maybe.
We'll get to a point where I think we reduce those number of scenarios by improved processes, but we're never going to get to zero because, like you said in the beginning, this is human beings we're talking about.
Yeah.
And speaking of human beings, we've come up on almost an hour.
Wow, that went by.
I know.
I like talking to you. Let's do some more.
I really enjoy this.
Yeah.
Like, I learned a lot from you.
Let's solve all the world's problems.
You know what? We'll solve all the things. And it all starts with drinks, because this is Vegas, and then it ends with more drink. No, I'm kidding. But Dr. Paul Teirstein, I want to thank you again for personally as a physician, because you care about other doctors and you care about patients and you care about staff, and that's why you do this, and you spend your energy and your hard-earned time and money yourself to actually actualize this passion of making it a more rational process by which we are certified. So I want to thank you for that. The call to action for people who are getting this far into the podcast is go to the links we're going to leave you in nbpas.org and check out the petition, leave your comments on the Vision for the Future report from ABMS, and let them know what you think. Whether you're a doctor or not, all of us are invested in having our physicians be appropriately trained, tested, and non-burned out.
Exactly. You are really good at this.
No formal training, Paul.
It's instinctive. I don't know what your parents did to you.
Yeah, that's what it is. It's not so much what's wrong with you, it's what happened to you.
Exactly. But you've got it. This has been great. Thanks
again, brother. Terrific. And we out. Peace.